If we don't express, our frustration level increases. If the frustration level increases, then we are not supposed to express. So what? So the expression is the king, expression is the kingdom, expression is what we have to go for, and expression is everything. That's why we need to express. Hello guys, this is Vidran Singh Saigal, pursuing MBBS from JRMC Gwalior. Now presenting a beautiful lecture on the great topic, that is peptic ulcers treatment. So let's get started. So guys, I have posted my notes on my Instagram account, that is the Integrated Medicos. Do follow it and subscribe to my channel. So guys, we have discussed the preclinical and disease portion in part 1. In part 2, we have also discussed the diagnosis, right? So in part 3, we will discuss the treatment. First, we will start with the drug classification itself, followed by the mechanism of action of drugs, followed by the individual drugs and the schemes and regimens with which we provide medication to the patient, and if it is needed, we will go for the surgery. So we will start. Okay, so we will start with drug classification. Number 1 is the gastric acid secretion inhibitors, in which 4 things will come. Most important thing is the PPIs, followed by the H2 antihistamines and the prostaglandin analogs and the anticholinergics. And the PPIs include the OME, ASOME, Panto, Lanso and Rameprazole, followed by the H2 antihistamines, in which cimetidine, ranitidine, famotidine and roxadidine are more common. Okay, followed by the misoprostol, which is coming under prostaglandin analog, and followed by the anticholinergic, which is the pyrazapine, propanthelin and oxyphenonium. So that is the first category, followed by another category, that is antacids or neutralizers. Number 1 is the systemic, another one is a non-systemic. Systemic will have the 2 examples, such as the sodium bicarbonate and sodium citrate, right? Followed by the non-systemic. First example is magnesium hydroxide, followed by the magnesium trisilicate and the aluminium hydroxide and the megalrate. Okay, followed by another class, that is the ulcer protectives, in which sucralfate and CBS, the colloidal bismuth substrate. Okay, and third and last category will be anti-H. pylori drugs, such as amoxicillin, clarithromycin, metronidazole, tinidazole and the CBS. The same thing present here, right? That is what the drug classification is, and we have discussed this under physiology of acid secretion. So we will see the clinical aspect of that. The 3 more common substance and the factors, such as this histamine and this ACH, and third one is a pump itself. Okay, these 3 things are just augmenting the release of the acid. So we will block all these 3 things, such as the blocker of this pump, right? And the blocker of what? Blocker of this H2 receptor, right? And the blocker of M1 receptor, or somewhat M31. Okay, so blocker of these 3 things are needed. And as we all know that prostaglandin E2 will decrease the acid output. That's why prostaglandin analog, that is the misoprostol, can be given to the patient. So that is what the mechanism of the first group, that is the gastric acid secretion inhibitors. Okay, in which the 4 classes are there, followed by the indications and the side effects of the secretion inhibitors, the acid secretion inhibitors. We have 4 categories: antihistamines, PPIs, anticholinergics and the prostaglandin analogs. The indications include, the commonest thing is the peptic ulcers, peptic ulcers, peptic ulcers and peptic ulcers. Okay, more commonly drug of choice is a PPI out of all these drugs, right? Followed by the bleeding stress ulcers, the complication or the complications it is, and the bleeding peptic ulcers are present and can be treated by giving PPIs more aggressively, followed by the GERD, that is gastroesophageal reflux disease. So we need to neutralize the acid, we need to inhibit synthesis of the acid to subside its symptom, that is the heartburn, right? If we aspirate the acid, that will result into the pneumonia. That's why it can be given as well. And the urticaria, the skin reaction, and the non-ulcer dyspepsia, the bloating component will be subsided. And GERD, it can, the PPIs can be given to the GERD, Zollinger Ellison syndrome, that is a kind of a gastrinoma. Okay, and followed by the stress ulcers. Okay, in those conditions, PPIs can be given. And the anticholinergics can be given to the peptic ulcers, but not given because of lot of side effects. We can give prostaglandin analogs to the patient in taking the NSAID. Okay, but the drug of choice is a PPI in this case as well. So guys, we have discussed the uses, the indications. Now we will go for the side effects of that. In the CNS, we're just having the headache, dizziness, hallucinations, and the convulsions in the toxic dosage. In the CVS, we're just having bradycardia and arrhythmia in the toxic dosage. And in the endocrine, we're just having gynecomastia, loss of libido, and the impotence. And the mechanism behind it is like that, the estradiol, which is converted and which is degraded in the liver, which can't be degraded, okay, in the liver, number one. Number two, cimetidine displaces the dihydrotestosterone from its cytoplasmic receptor, and that's why the testosterone functioning is hampered, right? And that also augments the release of prolactin. That's why such symptoms are presented here. Done. So that is what the side effects of cimetidine. Okay, other drugs of this category will have somewhat lesser side effects, right? So now we will discuss the side effects of PPIs. Okay, that is better tolerated, and that's why the side effects are lesser but still present, such as the nausea, vomiting, loose stools, abdominal pain, and the headache. Okay, and the decrease in the acid, decrease in synthesis of the acid, and that will hamper the absorption of calcium, and that will leading to osteoporosis. And if the protons or the acid is lesser, the reflex gastrin release is being increased. That's why the compensatory hypergastrinemia is present in this case. Done. Followed by the side effects of anticholinergics, such as the dry mouth, just opposite to the functioning of the ACH, such as ACH. What does it do? That goes for salivation, that goes for contraction of detrusal muscles in the bladder, that stimulates the motility of intestine, right? And what does it do in eye? That performs meiosis. So just opposite of that, so dry mouth, and the urinary retention, constipation, and mydriasis, followed by the side effects of the PG analog, right? So diarrhea and abortion, uterine bleeding, and the abdominal cramps are more common. Done. Followed by the antimicrobials. We're just having five main drugs in this head, such as first one is the amoxicillin, right? So mechanism of action is that is cell wall synthesis inhibitor. So the use is, we all know, peptic ulcers, followed by the respiratory tract infection caused by streptococcus pneumoniae or pneumococcus. Third one is the UTIs. Okay, so these are the uses of that. Side effects will be rashes and diarrhea. So we will go for the clarithromycin, that is the macrolide group of drug. So mechanism of action is like that inhibits translocation of the ribosomal complex over the mRNA, so that the protein synthesis is hampered here. Okay, so mechanism is done. Followed by uses. Okay, so H. pylori infection, we can use it. Okay, in the respiratory tract infection, we can use it as well. Followed by the side effects. Okay, the reversible autotoxicity, number one. Number two is the rhabdomyolysis. Basically, it is kind of a broad spectrum antimicrobial. That's why it is inhibiting the normal flora of GIT, and that's why the Clostridium difficile grows and resulting into PMC. Done. Third one is metronidazole. Mechanism include it is having the nitro group. And as we all know, the nitro group is electron deficient, that takes the electron from the metabolism, from the pathways of pyruvate oxidation. Okay, when it takes the electron, so that this pathway is not working, and that's why the inhibition of growth of the H. pylori and other protozoa will be taking place. That's why we use it in GRDSS, peptic ulcers, PMC. It is the side effect of the macrolides, but it is the indication of metronidazole. Okay, and amoebiasis and trichomoniasis as well are the uses of this, followed by the side effects: nausea, vomiting, abdominal cramps, skin reaction, okay, and the rashes, and the peripheral neuropathy and seizures are more common side effects of metronidazole. So we will discuss its brother, that is the tinidazole. Okay, and having the same mechanism, same spectrum of activity against protozoa, and that's why we give it for the amoebic liver abscess and intestinal amoebiasis and giardiasis and trichomoniasis as well. Adverse drug reaction. Since this drug is better tolerated than metro, that's why it is preferred. So we will discuss the last drug in this category, that is the tetracycline. Okay, the mechanism is that it inhibits the binding of tRNA, the activated tRNA, to initiation complex, so that the protein synthesis is not occurring. Okay, so the uses include that is effective against rickettsial infection, cholera, and the granuloma inguinale. So the side effects include that is a phototoxic drug, and the it causes the defective development and the formation of teeth and bone, and that is also contraindicated in the liver and the kidney failure. Done. Followed by, so we will discuss the antacids. So what is ANC? The acid neutralizing capacity. Okay, what is that? That is the number of equivalents of the 1NHCl acid to neutralize and to react with 1 unit of antacid preparation to bring the pH to 3.5 in 15 minutes. Okay, so what is the sodium bicarbonate? That is a systemic antacid, right? Uses include the heartburn, acidosis, renal tubular acidosis, and alkalization of urine. Done. And its side effects include, okay, so that is what is just making and producing CO2, causing distension of stomach, followed by the bicarbonates in blood, causing the alkalosis, followed by that increases load of sodium, resulting into water retention, edema, and CHF, the congestive heart failure. Okay, so that is causing the acid rebound. Once its effect is over, okay, so rebound, increase in the acid is taking place, which is the side effect of that. That is systemic one. Okay, so we will discuss non-systemic ones. Okay, so we're just having the magnesium hydroxide, aluminum hydroxide, and the magalrate, the combination of the two. Okay, and the uses include the heartburn and the acidity. And the side effects of this is the diarrhea. Why? Since magnesium ion that causes cholecystokinin release, and that also is osmotically active. Okay, so diarrhea is prominent in the aluminum hydroxide. What is occurring is that aluminum ion is just relaxing the smooth muscle. That's why it is causing the constipation, and that also causes defects in the brain and bone, leading to encephalopathy and the osteopathy. Done. So that is what the antacids. Another one is the ulcer protectives. Okay, so we're just having sucralfate and the CBS. Okay, so if the pH is less than 4, these molecules, the molecules of sucralfate, that will combine and that will polymerize. Okay, and that is what the abraded portion of mucosa. Okay, and that is the ulcer. Okay, so at the pH of less than 4, these molecules polymerize and bind with the glycoproteins of this layer, and the dietary proteins are just filling here and covering here, so that a protective layer is being formed. So that is causing protection of this ulcer to the acids, right? That is a lumen. Okay, followed by the CBS, that is the colloidal bismuth substrate. Same thing here. The pH of less than 5 is needed to polymerize, and the same mechanism is there. And the uses include the peptic ulcers, and the side effect of sucralfate is the constipation, and this is having diarrhea and the blackening of tongue and stools as the side effect of that, right? And the hypophosphatemia is a side effect of this as well. Done. Next. So we have discussed the each and every drug. Here the time comes to discuss the schemes with which we provide the medication to the patient. We're just having several schemes such as Clarithrol triple, bismuth quadruple, concomitant, sequential, and the hybrid. So what is P? P is PPI. What is this? A, amoxicillin, and that is clarithromycin, right? What is this? This is PPI. That is CBS, bismuth. That is metro, and that is the tetra. Okay, same thing is present here. We will provide this scheme for 2 weeks to the patient, and that is first week and that is second week. These are the drugs of first week, and that is the drug for second week. In the case of Clarithrol triple, that is PAC, both are same. Okay, and the bismuth quadruple, both are also same, PBMT. Okay, in the case of concomitant therapy, PACM is present in both these things, right? So PPI, amoxicillin, clarithromycin, and metro, same thing are present here as well. In the sequential therapy, what does it mean? Sequence. We need to provide PA first, followed by PNC later, right? In the hybrid, which is a hybrid between the two, so that is mimicking this and that is mimicking this, right? That is what the basic scheme and therapy, and with which we provide medication to the patient, and whichever is suitable we will provide the scheme to the patient. Okay, so we need to provide it for 2 weeks for better results. And the metro, the dosing, okay, all are BD according to BNF. Okay, all are BD here. And the dosing, so we will give 400 mg of metro, 750 mg of amoxicillin, and clarithromycin. If we are just giving Clarithrol with metro, the dose of Clarithrol will be 250, and if it is given with amoxicillin, the dose of Clarithrol will be 500 mg. Okay, and the PPIs, the dosing, the omeprazole 20 mg and the pantoprazole 40 mg will be given to the patient, right? Followed by the schemes for what? For antimicrobial selection. Whichever antimicrobial is selected for the patient, we will provide to the patient, right? We will have the penicillin under consideration. Okay, whether the patient is hypersensitive or not hypersensitive with respect to penicillin. Okay, if it is not hypersensitive with penicillin, we will check the macrolide, whether it is exposed to the patient or not exposed. Exposed means that patient may be resistant to macrolide, or non-exposed means patient is definitely not resistant to this. So in this category, okay, in this category, patient is not hypersensitive to penicillin and not resistant to macrolides. So any of the therapy can be given to the patient, such as Clarithrol triple, bismuth quadruple, concomitant, sequential, hybrid. So any of the therapy can be given to the patient. Okay, in this category, the patient is penicillin non-reactive. Okay, not hypersensitive. So that's a good thing. But it may be resistant with the macrolide. That's why we need to avoid the macrolide first as a first line. So we will provide the bismuth quadruple, which is not containing the macrolide and the penicillin. Okay, so we will prefer this as a first line. Okay, and the second line we can go for the sequential one, Okay, and the concomitant and the hybrid one. In all these therapy will be having macrolide, but these are present along with the penicillin so that efficacy is patent. Okay, followed by if the patient is hypersensitive, okay, to penicillin, the penicillin is contraindicated. Okay, that's why we will check for the macrolides. Okay, so if it is exposed, that means that is resistant, and if it that may be resistant, and if it is non-exposed, that surely means patient is not resistant. Okay, so in the case of non-resistance, we will start with the bismuth quadruple or PMC. Okay, in which this component is a macrolide, isn't it? The clarithromycin, which is a macrolide, and that is metro, and that is PPI. This scheme can be given. Okay, so in the second one, the patient is penicillin hypersensitive, penicillin is contraindicated, and we will check for macrolide, which may be resistant in this case. That's why we will prefer the bismuth quadruple, in which the macrolide and the penicillin both are absent. So what is present in this bismuth quadruple? PBMT. Okay, PPIs, CBS, Metro, Tetra. Penicillin is not present, macrolide is also not present. So that is safest in this case. That is what the selection of the antimicrobials to suitable person. If the patient is not being treated by the medications, we will go for the surgery, right? So we're just having two things. Patient may have ulcers in stomach or in the duodenum. If it is stomach, the treatment depends upon location where it is present in stomach. Okay, in the case of the duodenal ulcers, the treatment depends upon severity, how severe and what are the complications of that. Okay, so such as bleeding, perforation, GOO, that is gastric outlet obstruction. We will discuss these three things in next page. Now see the gastric ulcers, the modified Johnson classification, not criteria. The criteria is just for rheumatic fever, but we are just concerned about the peptic ulcers. So modified Johnson classification, what is that? That's having five classes: one, two, three, four, five. Okay, so depends upon the location, such as the class 1 is just having the ulcer at this position. What is that? That is the incisura angularis, present between the body and the antrum at the lesser curvature. Done. That's body antrum. Okay, in the second category we're just having two ulcers. Number one is at the body, another one is at what? The D1. Done. Third category, we're just having ulcer at pre-pyloric area, just pre-pyloric area. And the fourth one, that is present the high at what? At lesser curvature. Okay, high at lesser curvature. And in the fifth one, that is basically caused by NSAID. That's why it can be present anywhere. Okay, so anywhere it can be present, right? So that is what the location of the ulcers. We will discuss the blood group. Okay, so A blood group is just more commonly associated with class 1, while the class 2, 3, 4, and 5 are just associated with the O blood group. Done. C, check for the acid output. Okay, in class 2 and class 3 we will have the high acid output. So the ulcers are basically due to high acid concentration and luminal concentration, and that's why the high luminal acid will be leading to the ulcers, and the ulcers in the body and the D1 and the pre-pyloric area. In class 1, 4, and 5, these are not associated with the high acid output. Okay, and as far as surgery is concerned, the surgery for class 1 is distal gastrectomy. The distal portion, the antral portion of the stomach is just being resected out. Okay, right? So that this portion is resected here. Okay, followed by the second and third, in which we're just having a complaint of increased acid output. That's why we need to go for truncal vagotomy, the complete cutting and cutout of vagus. Since vagus nerve is just increasing acetylcholine and thereby increasing acid, that's why we cut whole vagus nerve so that acid is being decreased. So decrease in acid will be occurring because of truncal vagotomy and enterectomy. And we will just cut out this portion, okay, and we will cut out this vagus nerve as well, so that the permanent decrease in acid will be achieved here. So that is what the medication for class 2 and 3. Fourth class, we are just having named procedure such as Sanders, Pouchet, Killing-Mandliner, and the Shoemaker. Right? These are the four named surgeries performed for class 4. Okay, so in the class 5, we need to stop NSAIDs because NSAIDs are just causing the ulcers. That's why just stop it. Okay, so that ulcer will be treated spontaneously. So we will discuss the bleeding peptic ulcers, the surgical management of that. Right? So we will go for the duodenotomy, just incise here. That is duodenum incise here. And the ligation, since if we cut it, we will find there is presence of the artery that is bleeding. Okay, what is this artery? This artery, that is a gastroduodenal artery passing behind to the D1. Okay, just ligate it. Okay, so we have incise the duodenum, ligated the bleeder, and followed by that is the vagus nerve passing through, and just cut this vagus nerve so that acid output is completely suppressed and totally suppressed. Okay, and then followed by the pyloroplasty. What is that? We are just incising it vertically and suturing it horizontally so that strictures are not being formed. The duodenal perforation, the modified omental patch repair is done. So that is stomach, okay, and that is what? The greater omentum, okay, and that is perforated here. So we will take a vascularized pedicle of the greater omentum and just reflect it and suture this defect with this portion, that is a vascularized pedicle of greater omentum. Just reflect it and suture it here so that this perforation is sutured and blocked. Okay, that is the modified omental patch repair. The patch of omentum is just suturing here at the perforation site. So we will discuss the gastric outlet obstruction. So how do we diagnose it? We will diagnose it with the saline load test. Okay, what we do is that we pass nasogastric tube to the patient, right? We aspire the entire content of the stomach of the patient. Okay, so and then we will instill the 750 ml of normal saline to the patient. Okay, and the wait for 30 minutes. Okay, and after 30 minutes we will aspire the content of the stomach with this nasogastric tube, and we will estimate the volume of this. If the volume is lesser than 400 ml, that means the condition is normal, the gastric emptying is normal. And if the volume of normal saline and whatever the fluid coming out, it's if it is volume is more than 400 ml, it means the patient is suffered by the gastric outlet obstruction. That is what the saline load test. And what will be the treatment? Treatment will be the nil per oral, and we have to give the IV fluids, which is normal saline, to the patient. So that is the first line treatment. If it is not working, we will go for the truncal vagotomy and enterectomy. So that is our stomach. Okay, if it is the ulcer present here, we will go for the enterectomy. Number one, resect this portion, number one, followed by that is the vagus nerve, cut it here. Okay, the vagus nerve, the truncal vagotomy is there, and the enterectomy is there. Okay, if the fibrosis is extensive, if extensive fibrosis is present, that's why the enterectomy is not safe. Okay, that's why we need to go for the truncal vagotomy, same thing, but the gastrojejunostomy. We need to resect the whole portion, okay, out, and this portion of small intestine will be anastomosing with this stomach, so that the whole portion of extensive fibrosis is getting resected out, and the normal portion of stomach and the jejunum is being anastomosed with each other. Treatment of peptic ulcers. So thank you. for watching.
If you just have any doubt and query, you can go for the comment section below. Hit the like button for the sake of my motivation, and don't forget to subscribe. Pressing the icon will give me some like. Guys, we have finished our peptic ulcer series. Before we start another disease, I just want to tell you guys that we will produce the stress buster part 1. So till then, keep innovating. Thank you.